No problem. Can everyone see that? Can everyone see? Good?
Yes.
Yes.
Perfect. Perfect. So I'm Eileen Chaves. I'm a pediatric obesity psychologist, and I work at Nationwide Children's Hospital in the Center for Healthy Weight and Nutrition. Um, so today I'm going to talk a little bit about picky eaters and other sort of conditions that might cause food sensitivities. I'm trying to go forward on my slides. Why is that not working? Maybe if I click. Oh, okay. So I have nothing to disclose. So how many times have you worked with a family and they talk about giving their kiddo a vegetable or a new food, and this is the face they make? Or that face? And then parents make these faces. And then eventually, this is kind of what happens. And then nobody's eating anything. So a couple things that I really wanted to do with this talk is I really wanted to define what picky eating is. I wanted to talk about what is sort of age appropriate with picky eating and what is more sort of problematic or what may need more treatment. Then talk about some behavioral interventions that can be really used to help increase food acceptance in kiddos with picky eating. And then how you know when to refer and who you might refer to. So let's start out talking about what picky eating is. And in the literature, you will find lots and lots and lots of different definitions of picky eating. There is not a lot of consensus. So these are just some of the multiple definitions of picky eating. But I think in general, picky eating can really be thought of as the unwillingness to try new foods or foods that kiddos have eaten before and are now sort of refusing. Especially vegetables, and then kids that have very strong food preferences. And these food preferences may be very sort of brand or location specific. Like I work with families whose kiddos only eat burgers from McDonald's. And if you would buy them a burger from somewhere else like Wendy's, they would totally know the difference and they would not eat that. But it can also be food preferences in terms of like texture or temperature or color. So just in general, sort of strong food preferences. Okay. So I think when we think about this, it really sort of begins to develop around that sort of toddler time. So kids go from being infants, and then toddlerhood is really that time where kids really want more autonomy, want more sort of independence, and they learn that word no. And they use that word no a lot. I have a 3-year-old right now and a 13-month-old. And the 13-month-old, luckily, is sort of still in that baby phase, but the toddler is very much about no. And so that is very developmentally appropriate, but that no can then extend into feeding. And so one of the things that happens for kiddos around that 2-year-old age is they develop neophobia. And neophobia really just means sort of a fear of things that are new. It doesn't relate necessarily to food, but it can be about food if it is food neophobia. So then what is sort of average or typical picky eating? So your average or typical picky eating usually begins around that 18-month-old time frame to the 2-year-old time frame. It generally sort of is thought to decrease or improve around that 4 or 5-year-old time frame. But average or typical picky eaters are kiddos that eat at least 30 different food groups on a pretty regular basis. 30 different foods on a regular basis, and they eat from a variety of different food groups. So at least one food from each food group, even if they have very sort of specific preferences about what those foods are. These are kids that may suddenly stop eating a food that they used to like. But if you offer that food again later, while they may sort of initially refuse, they'll probably pick it back up again. Without any sort of rhyme or reason, they'll just usually start eating it again at some point. They may eat inconsistent amounts. And what I mean by that is some days they may really feel like eating a lot. And other days they may not feel like eating a lot. So parents can get kind of frustrated because you fed them a meal last night and they ate it all. And then the next night, they're really kind of refusing and not wanting to eat it. But that is pretty age appropriate. Um, if you give them a plate and it's got both things that they prefer and things that they don't prefer, they usually do okay with that. They may not eat the non-preferred foods, but typically they will not sort of have a meltdown about having non-preferred and preferred things on their plate at the same time. Um, they'll usually start to gradually add foods to their list of preferred foods. So as they sort of get older and they're exposed to more foods, the number of foods they'll eat sort of goes up. Um, and they'll usually be okay with eating with their family. So even if they're eating things that are different from their family, they're usually okay with sitting at the table with their family while family are eating different things. So with the more average or typical picky eaters, what can we do to help caregivers? So I usually talk to parents about if you want your kids to eat certain things, you really need to model eating those certain things for them. So if you want kids to eat vegetables, they need to see you eating vegetables. If you want your kiddos to eat things with mixed textures like casseroles or other sort of dishes, you need to also be eating those things too. I think where parents can kind of get into trouble is if they are sort of having the expectation that their kids eat those things and yet they never eat those things in front of their kids. Um, Parents need to provide very regular, consistent meals and snacks. This helps decrease kids' anxiety about knowing when they're going to eat. It helps decrease kiddos asking all the time for like certain foods or just kind of wandering into the kitchen or really sort of perseverating on food. If they know when the meals are and they know that they're definitely going to eat again, that can really help with that. Um, Asking caregivers to really limit food or drink in between meals and snacks, except for water, of course. If kids sort of learn that they can fill up on preferred snacks or preferred drinks, they're less likely to want to interact with those newer foods at scheduled meals or snacks. Um, Parents should really continue to expose kids to a wide variety of foods, even if that kiddo has said no to it before. So again, I think where parents can really get into trouble is when a kiddo has sort of had a meltdown or said no to a certain thing, parents can get the idea that that was a really unpleasant experience. I don't want that to happen again at dinner time or at breakfast or whatever. So I'm just not going to offer them that. They don't eat that. And what that kiddo very quickly learns is what they need to do then is sort of pitch a fit or say no or really refuse. And then it becomes behavioral. And all they have to do is do that to get out of being around that certain food or being asked to eat that certain food. So parents really need to continue to offer foods that kids have said no to, even if the kiddo doesn't necessarily eat it or interact with that food. So encourage interaction with food. And again, that doesn't necessarily mean eating. So that may be just like leaving that new food on your plate or asking a kiddo to pick up that food and smell it, pick up that food and sort of give it a kiss or lick it, or maybe put it in your mouth just to sort of feel what it's like, maybe bite down on it and then spit it out without any expectation to actually go ahead and swallow it. And it can also mean like playing with food. So, like little animal crackers you can play with. You can like use little different vegetables and stick them in like pudding or jello to sort of make like little different towers. But really exposure to food and different types of food is really helpful because then at least kids are interacting with that thing and getting used to that thing. Parents should start to praise their kids' desired behaviors. So if whatever that expectation that you sort of said is, if it's to leave that new food on your plate, or if it's to give that food a kiss, or if it's to like put that food in your mouth and just take one bite and swallow it, make sure that parents know that they need to be praising those behaviors and that praise needs to be really immediate and very specific. Um, and so when I talk to parents about how to give praise, I really talk about it's more than just good job. Effective praise is behavioral and specific. So it's, I really love that you let that new food sit on your plate and didn't really sort of throw a fit about it, right? Very specific and behavioral. And then for any sort of undesired behaviors, parents should really use planned ignoring. So if a kiddo is like gagging or making faces or saying no to that food, just take your attention away And when kiddos start to interact with that food or that behavior, like the fussing or the gagging or whatever sort of goes away, you bring your attention back and you start giving praise for the desired behaviors. Okay. Um, so now what do we do when a kiddo has extreme picky eating? So these are kids that eat less than 20 foods on a regular, consistent basis. They may refuse whole food groups. Um, they may stop eating a food that they already liked, and then they just never get it back, right? So I have lots of parents that talk to me about like lost foods, right? Like, oh, they ate that when they were like 1.5, but they haven't touched it since they were 3. They may have sensory aversions to different types or textures of foods. So these are kiddos that may have difficulty with foods that they consider to be mushy or slimy. And I've had kids describe things like cottage cheese or yogurt as really sort of slimy foods that they have a hard time with, or squishy foods. Like sometimes they'll talk to me about like fruits, like certain fruits, like pears, being just really squishy and not liking the sort of gritty texture of that food. These are kids that may start to really lose weight, and you see them sort of falling off the growth curve because they're not eating enough and they're not eating enough variety of foods. Or, and these are the kids that I'm more apt to see just because I work in the Center for Healthy Weight, these are kids that really start to gain weight due to their food preferences. So if they will only eat very processed foods, or only eat foods that are like fast food, they may start to gain weight because that's all they're really eating. If you offer them a new food or a non-preferred food, they may get really upset. And I have parents talk to me about kids that like every mealtime is a battle just because you offer these things. And kids will like push the plate away or tip the chair over or immediately start crying or run away from the table. It becomes a struggle just to add any new foods to their list of preferred foods, and they almost always eat something very different from the family. So this is like the caregiver who's sort of making a very separate meal for this child, or going out, like if the kid will only eat fast food, going out and specifically getting them fast food while the rest of the family is eating sort of home cooked family foods. So how do we help these kiddos? I don't know if everyone is familiar with Ellen Satter, but Ellen Satter is a dietitian. And she developed this idea of division of responsibility in feeding. And so she talks about parents having certain responsibilities related to feeding and children having certain responsibilities related to eating. So parents' responsibilities are really to offer, or really to decide what foods to offer, when the food is offered, and where the food is offered. So what that means again is really offering a variety of foods and parents making the decision about what to offer. So offering both preferred and non-preferred foods, having foods that kiddos like and that they are learning, deciding when food is offered. So deciding to have like scheduled meals, scheduled snacks, as opposed to just sort of letting kids go and sort of grab snacks or drinks or whatever in between meals or whenever they sort of want. And then having a very specific sort of place or plan about where that food is offered. So it could be the dinner table, it could be somewhere else in the house, but really trying to limit distractions. So limiting any sort of screens, or anything else that might make it difficult for children to sort of be present and mindful when eating. And then kids' responsibilities are really to decide how much of that food to eat, and if they will eat, because there may very well be times that kids choose not to eat. And so then I usually talk with families about sort of understanding that that is the child's choice, and that when the child is ready to eat again, or when it is the next scheduled meal or snack, sort of offering that meal again. And I know last week in our presentation, our wonderful presenter talked a little bit about ARFID. So I just wanted to like touch on it really sort of briefly. But ARFID stands for Avoidant Restrictive Food Intake Disorder, and it is a newer diagnosis in the DSM-5. Before the DSM-5 came out, it was really referred to as selective eating disorder. But it can affect up to 5% of children, and boys are usually at greater risk for ARFID. And overall, about 3.2% of the general population can be diagnosed with ARFID. And for kids in any type of eating disorder program, the numbers range from about 14 to 22.5%. And oftentimes, anxiety plays a very significant role in this disorder. These, again, are the kiddos that, like any thought of eating something new or being asked to even just interact with a new food can really, really, really make them very, very anxious, very panicky. And then you might get the food, like the refusal behaviors. And some of it can also be sensory, and the anxiety can be related to that sensory aspect, because if they are being asked to interact with something that is going to be really upsetting to them from a sensory standpoint, you get anxiety. So just some diagnostic criteria for ARFID. I won't read that slide to you, but I did want to just sort of touch on what the food intake of someone with ARFID sort of looks like versus someone that does not have ARFID. So using the My Plate sort of feature, there was a study that was put out that really looked at how much food in each food group someone diagnosed with ARFID sort of ate typically. And what they sort of found was that children with ARFID were eating a lot more grains, and that could also be very processed grains. They were drinking a lot more of their calories. So those calories were more sort of dairy based, right? But eating a lot fewer fruits, a lot fewer vegetables, and a lot fewer protein. So because they're eating more of the sort of processed foods, the more sort of grains, those are carbohydrates, and they're typically getting, they may either they're really not hungry because like food is not their thing, or in the kids that I see that sort of are in that overweight or obese category, they are getting hungry because those carbohydrates are breaking down into their body into those sugars, and then causing their blood sugar to really drop, and then feeling really hungry again and sort of doing more food seeking, but for the very preferred foods. So really quickly, just a few other conditions that might contribute to picky eating. I've worked with some kiddos that have significant food allergies, and they oftentimes can develop anxiety about not only the foods that they are allergic to, but just sort of food in general. Food is sort of this threat, right? So they have a hard time eating other foods that they may not have any allergies to, just things that are sort of different or new to them. And even if other people are telling them like, no, this is not going to cause an allergic reaction, kiddos may have a really hard time with that, just because they sort of view food as this threat or this sort of enemy sometimes. So that it looks like picky eating, but the cause or the reason is different. Autism spectrum disorder, because of that anxiety aspect and because of that sort of sensory difficulty sometimes related to food. And then kiddos that have had a choking event while eating or drinking, again, this kind of looks like picky eating, because at that point kids might just refuse all foods or all certain types of foods. Like if they had a choking incident on something that was more chewy, or something that was more crunchy, they may then just kind of refuse either those specific types of food or all food. And then sensory processing difficulties, which I feel like we've talked a little bit about. So I wanted to just share this idea of food chaining. And I know that other individuals like speech therapists and occupational therapists use this too. But for people who aren't familiar with this approach, food chaining is this really nice behavioral way to help kids take what they're eating now and sort of work to eating something very different. So this picture that I'm sharing right here is a food chain that sort of helps kids get from kids who'll eat fishy crackers, which I meet a lot of kids that will eat and accept fishy crackers, to moving on to eating like broccoli, right? Which you think those two things aren't related, but if you chain them and sort of do this shaping, you can get there, right? So you would first ask kids what they're preferring, and I usually take a very detailed diet history where I ask parents to sort of tell me all the foods kids will eat at breakfast, at lunch, at dinner, at snacks, because then we can sort of move on from something that's preferred and we know that they will eat to something that's just a little bit different. So for example, a different shaped cheese cracker, like a Cheez-It, and then to move on to a cracker that is a little bit different shape, a little different flavor. So maybe it's like a Parmesan flavored cracker. And then to move from there to cheese and crackers, then to cheese on something that has a little bit different texture, like wheat, like whole wheat toast or just toast. And then change the temperature of that food to make it grilled cheese. And then go from there to potatoes and cheese, which I think is especially helpful if you know that kids eat French fries. I meet a lot of kids that eat French fries. And then from there to a potato with cheese and broccoli, little bits of broccoli, and then hopefully from there you can get to broccoli and melty cheese, right? So I feel like this image makes it look very sort of linear. In my experience, this process is oftentimes not linear, and it is certainly not necessarily quick. But it can, like, you can get there, right? Like, you may have to work on the steps, sometimes a lot of exposure to get to that next step, but you can totally get there if you have parents who are sort of having expectations that we're going to kind of work on this every single day, and you have kiddos that are willing to sort of just tweak the things that they're doing, right? And so then really quickly, like, when do you really ask for a referral? I think referrals are very appropriate and very helpful when you have a child that is gagging or vomiting at each meal. I have met kiddos and worked with kiddos that vomit not even when anything is in their mouth, but just by the smell or the sight of a certain different food item, right? If kids are really not eating enough and it is really impacting their health, their emotional health, their social development, if parents really tell you that the behaviors that they're seeing at mealtime, they're just not able to handle. So there's a lot of conflict at meals. There's a lot of food refusal, um, a lot of whining or crying for very specific preferred food items. If a child isn't chewing well, so they're either having motor issues with chewing, or they spit food out, or they just can't keep the food in their mouth. If they're swallowing food whole, sometimes I meet kiddos who are eating very fast and parents are like, they're not even chewing, they're just swallowing it. Again, mealtime causes significant stress or conflict for parents, child, or both, or kids seem really, really overly anxious either at mealtimes or just when food is mentioned. So then where do we refer? So there are lots of different people who sort of help with feeding. And feeding teams are usually made up of a variety of people who are very multidisciplinary and work together. So occupational therapists help kids, of course, with sort of daily habits related to just living, and with feeding related things, they help with being able to sort of desensitize sometimes kiddos with texture issues, and being able to help kids with like motor tasks to get the food to their mouth. Speech language pathologists, of course, are very trained in like knowing what is going on with the muscles of the mouth and with swallowing, and they can help with that. Dietitians really, of course, talk about food intake and how we can incorporate more calories in different types of foods. And then psychologists really help with some of those behavioral strategies related to anxiety, motivation, reward, attention, decreasing attention, things like that, and helping really sort of talk about family structure at meal times, and family expectations related to eating and feeding. So again, I was really trying to aim for noon being finished, and I think I did it. So any questions?